All right. And if, for a lot of people who, of course, who can't come tonight, I will be repeating this. I just have to figure out when. Okay. All right. Tell me if you guys can see my screen okay and are seeing my PowerPoint. Good, guys?
I can see it.
All right, let's get this show on the road then. Eating disorders. So interestingly, I think that it's one of the diagnoses that intimidates me the most. I'm interested to see how other people feel. There's something about eating disorders and how kind of scary they are, and how much shame there is inside the patients. I feel like it's one of the diagnoses that I often don't find out that the patient has until I've been working with the patient for years at times. I've heard doctors say, oh, I don't have eating disorder patients, or I don't treat eating disorder patients. And I always think, you know what, you do, you just don't realize that they are there because it's so hidden. So if you think you're not treating any eating disorder patients, you are. They simply have not revealed themselves yet. And so I'm hoping after the presentation today, I certainly think this was the case for me in creating this presentation. I felt more empowered to more directly go after these symptoms and discover more eating disorders and treat them. So we're going to start with ARFID. Avoidant restrictive food intake disorder. So basically, these is often in kids, but I'm seeing it happen a lot in adults too, that they are afraid of choking or vomiting. So they stop eating or they're only eating pureed stuff. They lose their appetite. They're just like feel like they have to force themselves to eat, right? So this is a failure to eat that is not driven by fear of gaining weight, as in anorexia and bulimia. Now, of course, some of your anorexic and bulimia patients will tell you that, no, I'm just not hungry. So if a patient's like, oh, no, I'm not hungry, and I'm eating all these bland kid mac and cheese foods, vanilla ice cream, mac and cheese, ARFID. But if they're like, I'm not hungry and I'm only eating fruits and vegetables and crunchy things, that's probably anorexia flying under the radar. These are classically the kids where the mom is searching all around when the store runs out of their particular brand of cheese sticks to get the special cheese stick brand. So there's a lot of comorbidity here with anxiety disorders and autism and avoidant restrictive food intake disorder. It's not just picky eating, okay? The physical exam pretty much matches that of anorexia, in terms of the same toll it takes on the body: low heart rate, low blood pressure, low temperature, EKG with changes, low bone mass. You want to check not just routine blood work with these patients, but also for micronutrients such as magnesium, phosphorus, zinc, iron, vitamin D, folate, and B12. And rule out stuff like achalasia, celiac disease, IBS as doctors. Okay, so treatment. Occupational therapy to help with the swallowing. Okay, a nutritionist, and the core of treatment is cognitive behavioral therapy that's specific to avoidant restrictive food intake disorder. So fortunately, in my research for this presentation, I came across an awesome workbook. If you go to that link And this is going to be included in the resource list. All the links are that I email out after the presentation. Massachusetts General has published a free cognitive behavioral therapy avoidant restrictive food intake disorder workbook. And some of these pictures on these slides, I actually stole directly from there, like this one, stolen from that workbook. So the cognitive behavioral therapy focuses on setting goals for patients to gradually expose themselves to the foods that they fear in small amounts. Like you have to take 5 tastes of this and 5 tastes of that, okay, and work their way up from there. It uses strategies like if someone's afraid of choking, they'll eat applesauce, but not an apple. So they'll have to cut up the apple and put more and more pieces of apple inside the applesauce to transition towards solid foods. Trying out different spices is a strategy. Or if they'll eat potato chips but not vegetables, they try to transition themselves with veggie chips. Eating all the components of something that's scary, like the cheese, the sauce, and the pepperoni of a pizza before they actually try to eat the pizza. It also includes what they call interoceptive exposures. So for those of you who haven't heard that term, interoception is our body's perception of internal cues like hunger, cold, I got to go poop, those kinds of things. Those are often impaired in patients who have ARFID. They may have a significant aversion to the feeling of fullness in their stomach. So some therapists help them do exposures and gain mastery of this by chugging water, and doing exercises to rate their hunger so they start to actually recognize their hunger cues. So all of that is with the help of a good therapist. The medication strategies. Honestly, I use olanzapine a lot for these patients, and you don't have to do much olanzapine. Like we're talking 1.25 milligrams of olanzapine, like an hour before the meal, I find really helps. And not just with increasing the appetite, it sort of has a calming effect too. Options are heptadine, tazapine, and of course SSRIs to go out with anxiety. But with like an underweight, food restricted, ARFID kid, often with autism, or severe anxiety disorder, I'm going with the olanzapine to get to stabilize their weight because, as discussed later, if weight is unstable, then or weight is low, sorry, and the brain is in starvation mode, it doesn't well to SSRIs. All right. Next, we're going to go to anorexia now. Before I move on, I will pause. Yes, you're going to get the slides later. I'm going to pause and take questions. If anyone wants to chime in with a question about ARFID.
I have a question, Dr. Greeter.
Hey, that's my friend Andrew. He's the best.
Hi, Dr. Greeter.
Right
Thank you so much. What's that?
Thanks for joining. I can hear you, but I can't see you.
Yes.
But thanks so much for joining me, Andrew.
Absolutely.
Andrew is a mentor and friend, and I trained in residency and fellowship with him for anyone who's interested.
Absolutely. Thank you so much, Dr. Greeter. This is really, really important information. One of the quick questions I had, just because olanzapine can seem like a pretty scary medication,
Yeah.
especially for non-psychiatrists and even some psychiatrists, actually. And so I didn't know if there was any comments you wanted to make as far as any monitoring regarding, just because it's a robust atypical antipsychotic. Is there anything you monitor in specific? Because I assume you're using it primarily for the calming effect like you described, but also too for kind of the increased appetite. And so is there any monitoring that you recommend?
And I guess honestly, because the data is that it just works better than the SSRIs for these patients. And a lot of them are pretty severely underweight. And so it seems to work in these underweight situations where SSRIs. In terms of monitoring, I mean, I get more worried when a patient is overweight, but I mean, standard of care would be checking a hemoglobin A1C like every 6 months of increased risk of diabetes, and checking their cholesterol, and making sure they're developing any like dyskinesias, which are pretty rare with olanzapine. What would you recommend to people, Andrew?
Thank you. Yeah, typically for just with atypical antipsychotics, and I typically use them in children with autism. And so, everything you said, a lipid panel, CBC, chemistry panel as well. And then I check the thyroid as well as hemoglobin A1C. So in my head, it's 5 things.
Really, you're checking the thyroid, huh?
Yeah, it's, if I'm going to go in and kind of check all of those things, typically speaking, that, just in case, honestly, that's less of a concern as far as metabolic, but typically if it's a mental health issue, especially I would imagine for dietary issues, the last thing you want to know is, is this kid, have a thyroid dysfunction that we don't know about that's affecting his appetite. That seems reasonable to me. And then as well as a AIMS assessment, the abnormal involuntary movement, just because you have that risk of tardive dyskinesia.
Yes. And then, since we're talking about like checking to make sure we're not missing anything, I probably should add a TSH to this slide. That's true. That's a good point, Andrew. But yeah, we want to rule out celiac. We want to rule out something going on GI, like IBS. And we want to even check like B12, folate, vitamin D, iron, ferritin, zinc, magnesium, and phosphorus with these low weight patients.
Can I ask a question?
Yes.
Please. I've never ordered a zinc level before. Is there any trick to ordering it? Is it like particular type of zinc?
Not that I know of. I just wrote it on the script and I didn't have a problem.
Okay. All right. And is it like vitamin D where, despite normal levels, you might recommend somebody have
like, why not, right? There's evidence in anorexia, which I'll cover this later, that zinc supplementation produces weight gain.
In anorexia. Okay.
Yes.
Right. But we're looking
why wouldn't it in ARFID? You know what I mean?
Sure. So is there a certain level that you aim to supplement to?
That I would defer to primary care, or I'd have to look it up because I honestly don't know the answer to that.
Okay, that's
good
fine.
question.
All right, thank you.
Yeah. If anyone else knows the answer, please chime in. For sure. Yeah. Other questions on ARFID, guys, before I move on to anorexia? No? Cool, thanks. All right. Anorexia. So, intense fear of becoming fat, a distorted view of themselves, and restriction of food intake such that they reach a low body weight. So if there are 2 types here. If they're binging and purging, but they're not low weight, we call them bulimia. If they're binging and purging and they are weight, we call them anorexia. Okay. If they're low weight and they're not doing any purging or binging, we call them just restricting type. And don't bother reading this, but if someone wants a great reference slide, because I know some people print these slides out and use them as a reference later when they encounter their patient, here I stole this table from DSM-5 to, divide it up. I'm going to really focus it kind of on the psychology of these disorders and the treatment though, versus like all the DSM-5 stuff. Anorexia is highly heritable. Actually 44% genetic concordance for monozygotic twins. And, I think that part of what contributes to shame in this disorder is people say that it's a self-created disorder because people want to look like a Barbie doll, that it's more of a Western, industrialized, wealthy civilization disorder. And that's not the case. I actually read a great book on, it's called Cultural Psychiatry, Psychiatry of Different Cultures. And anorexia exists in other cultures. It may not manifest in those cultures as a fear of gaining weight. It might manifest as a fear of abdominal fullness, interestingly. So the fear might be different, but everything else about the presentation is the same. It's not a cultural illness caused by Barbie dolls and social media, though certainly social comparison does not help. And it is not just women. It also occurs in men. I didn't know until I did this presentation that Dennis Quaid, he had to lose weight for a role. So he starved himself. And then as he starved himself, he started developing an eating disorder mindset. There's actually a study, I think it was the Minnesota starvation study, where they took men and they food restricted them. And these men under food restrictions started to display eating disorder behaviors. I'm going to pause here and show a video, okay, which actually is from Britain. So hold on, share screen, with some men talking about their eating disorder, okay? Share. Oh wait, hold on. All right, I have to open it. Give me a second, guys. All right, here we go. All right. No. Okay. Just go to basic screen share. Okay, I think it's going to work now. You guys can see consider eating disorders in men on the screen. Okay.
One of the reasons why I was reluctant to seek help was because I thought I'd be judged. I guess society had made it a feminine illness.
I think what GPs need to know or understand is it's non-gender specific.
And it is not about control. That's my own personal perception. It's about security. Your eating disorder is body armor.
Well, you know, if you know somebody's doing a lot of exercise, maybe that's consider it could be an eating disorder.
Yeah.
But it might not just be, oh man, it's amazing you're doing loads of exercise, you're so healthy.
Often, what I've wanted in the early stages of seeking help is for it to be accepted, to be known about, for it to be in the room. I want first and foremost to be listened to, somebody to just hold the space, be empathetic, and for it not to feel like I'm being judged.
From my experience, it can be very frightening to expose the thing that you might be very ashamed of. If someone's going to suddenly snatch it off you or try to remove that way of coping, that can be very threatening.
For that GP, it's 10 minutes of the day, but for that patient, that's weeks, months, potentially even years of thinking about this.
Depression's what I went in for, so it was the crisis point of the depression that got me to go.
My eating was a total mess. I was beginning to have severe gastrointestinal problems. I was having heart palpitations, but I looked bloody fabulous. So my GP was like, oh, you'll be fine.
You already feel terrible about it, but one of the things that was really helpful was when my GP just said, I'm worried about you. She would ask how I felt about this procedure or that treatment. That sent a really powerful, empowering message to me. You're part of the decision making here. I'm not going to force you to do anything.
What was difficult for my GP to understand was the eating disorder was fulfilling a function, so to then suddenly have to deal with it was terrifying.
Somehow you think that if you ask for help, that proves you're a failure.
My GP was great. She really knew the local charities and was like, in the meantime, whilst you're waiting on a referral, here's some groups that can help you. And she was really empathetic. She would always make sure I knew when she was working, and like so that I could book appointments with her, as opposed to having to repeat it to someone new every time.
A GP once said to me, I'm not exactly sure who I should be referring you to. I'm going to have to ask one of my colleagues and I can get back to you. And that honesty was great.
It's a complicated process. There's no easy fix, and no two people are the same. I think that's important. We don't all fit into one box.
My GP knew that it was nothing to do with food, but me as a person.
I think giving hope helps. Instead of saying you're going to take the eating disorder away, saying we can give you your attention span back, your love of life back, intellect back, fun back, your personality, your relationship with yourself, with others. All of these positive things rather than taking away stuff.
Okay. So I like that the video talks about how helpful it was to these patients to feel that their primary care could handle this shameful, difficult, painful thing, and how they viewed the eating disorder as basically their best way to cope with extremely painful feelings. We're going to talk also about strategies that I use to get people talking about shameful, embarrassing stuff too. We have a question. Marissa says, in what way do they not do well with SSRIs? So essentially in studies, they find that patients with anorexia who are underweight, the SSRIs do not separate from placebo, but when the weight is restored, they do have benefits in terms of less eating disorder behaviors, less eating disorder delusions on SSRIs. That's what we're talking about here. And the hypothesis is like, one hypothesis is, you need tryptophan from the diet to make the serotonin. Another hypothesis has to do with like the way the brain changes. You actually lose brain volume when the brain is in a starvation state. And we find that the more weight that patients lose, the more fixedly rigid their delusions become, and entrenched the eating disorder behaviors become. Okay, so now I'm going to go back to the PowerPoint and we're going to go into more detail on anorexia. Okay. You guys see my PowerPoint? Okay. Okay, tell me if you don't. Okay. Bulimia. Something that was mentioned in the video is how people can be missed because they don't look like they have an eating disorder. Actually, the woman, Jenny Schaefer, who wrote the book, Life Without Ed, which is a great book, and I'm going to play a song that she wrote about her eating disorder later. She had a very painful experience where she showed up to a physician and the physician told her, quote, "You don't look like you have an eating disorder." Because it was twofold. It was like, maybe all these therapists and people have been lying to me and I'm really fine. Or, geez, am I so fat that I don't look like I have an eating disorder? I think it's very important to recognize that patients who aren't underweight or patients who you wouldn't usually think have an eating disorder still be on the lookout. You can also be a normal weight and still experience life-threatening complications, especially the cardiac ones. So bulimia has the same fear of gaining weight, but there's these binge eating episodes, then the feeling of guilt, shame after the binge eating, then the purging, which could be vomiting, but there's other forms of purging, abuse of laxatives, excessive exercise, And you have to understand that for these patients, like he mentioned in the video, their binging and purging are their best effort to cope with incredibly painful feelings. So if they're told you have to stop binging and purging, there has to be something that they gain, right? Because this is sort of like a lifeline to them. People with bulimia tend to have a certain temperament, okay? That is that they're very emotionally dysregulated. They have an increased sensitivity to the reward of food. And they tend to be impulsive and sensation seeking. Generally, people with bulimia also engage in other unhealthy behaviors that they use to regulate their emotions, such as drug and alcohol use, shoplifting, cutting. There is some overlap between bulimia and borderline personality disorder and between bulimia and ADHD. So really recognize how in bulimia, there is a significant deficit in impulse control. Whereas in anorexia, we'll see, there tends to be an excess of that. So in bulimics, I've heard it said it's like the binging and purging give them temporary relief for long-term agony. Temporarily, they feel unashamed. They feel like they have value because they were able to restrict. Yay. And then the binging temporarily gives them relief of their anxiety. And then the shame and the guilt come back and they purge and the cycle repeats. So understanding the psychological value to these patients of these behaviors is very important in their treatment. Now, the anorexia temperament, which by the way, often predates the onset of the anorexia behaviors, is marked by extreme anxiety, rigidity, so harm avoidance. These are not risk takers, okay? They tend to be very adverse to any kind of loss. It's associated with decreased reward in the brain in response to food, whereas in the bulimia patients, there is an increased reward in the brain in response to food. They, as opposed to the emotional dysregulation of the bulimics, these patients with anorexia tend to have emotional blunting. They also have increased anxiety in anticipation of food. So for an anorexic patient, food is a very scary, painful thing. I've heard one quote from an eating disorder book I read was, "Nothing tastes as good as skinny feels." So that thinness is such a powerful thing for them. Why is that? Also, interestingly, side note, anorexics have less risk of substance abuse than people who don't have anorexia. So there's actually lower rates of substance abuse in the anorexia population than in the general population. It's protective against that because they are so adverse to risk. Okay. Some quotes. It's being in an abusive relationship where 1 minute it's spewing hateful thoughts about you and the next it's apologetically promising that if you listen to what it says, you will achieve happiness. It is your secret shame and your greatest accomplishment all in one. So it's kind of like the thinness is their surrogate for self-esteem. Their self-worth is entirely consumed by being thin. Okay, if I don't get an A on my test, I'm still thin. Am I the thinnest person on the elevator right now? All right, then I'm doing all right. It also helps them feel less powerless and helpless. Restricting means I am in control of my life. Eating means you're out of control and weak. So they look at her. She's eating a cheeseburger. She has no self-control. And it tends to have this delusional sense of self as fat and overweight. And that if only they were a little thinner, then they wouldn't be miserable anymore. If I just lose a few more pounds, I'll finally be happy. It's a very, very powerful disorder, guys. So Jenny Schaefer who's a country music singer. I'm gonna like play just a little bit of her song in a minute. Has a good quote from her book, which she wrote, Life Without Ed, How One Woman Declared Independence from Her Eating Disorder and How You Can Too. I recommend this to patients a lot, as well as the 8 keys to recovery from an eating disorder. So eating disorders are about excessive control, painful perfectionism, and stubborn self-hatred, not whether or not your thighs touch or the number on the scale. So I'll let you listen to an excerpt from her song, at the end of the presentation, just in case I start to run out of time and lose people. Okay, we'll come back to her. So shame is a huge component that prevents people from seeking treatment earlier. It thrives in the darkness of secrecy and solitude and does not survive the light of open acceptance and human connection. So you may not have the answer for your eating disorder patient, but simply directly acknowledging the disorder with them and not rejecting them is very powerful. Whatever is like there's this pregnant pause sometimes in the conversation, like you're talking to a patient and you just get the feeling there's something painful and shameful in there. So let patients know. I actually specifically say, just so you know, I can handle whatever you need to tell me. It's so simple, but I get a lot of traction out of that one. I can handle whatever you need to tell me, and then pause and see what comes out. Let them know that you won't reject them or dismiss them, that you have the courage to discuss these uncomfortable things directly. Also, when your patient says, "Hey, I'm going to stop," say, "That's great." But also, part of stopping drinking, stopping binging, stopping cutting, you name it, means that there's going to be relapses. We expect that you're going to relapse. That's part of this illness that we can handle together. You tell me when you relapse. And when you relapse, just do the next right thing that we'll figure out together. I also try to get them to name one additional person they might be willing to bring to an appointment, or they might be able to share the information with next to get support from. This is very a la Brene Brown, who's written a lot of great books if you guys are interested. She's a shame researcher. Her quote is, "Shame derives its power from being unspeakable." One of my patients was telling me about their dentist, right, who kept kind of like making subtle kind of implications, like, "Gosh, there's a lot of acidity in your mouth." Okay, this is a bulimic patient I'm doing therapy with right now who's been purging for like 40 years of their life, right? Okay, their teeth are terrible, right? And she was saying how she's like, "Yeah, I just wish my dentist would say, hey, I know you're purging. What kind of help are you getting for that?" It's not easy to bring this up, but patients really appreciate it. So what you'll notice on physical exam is low heart rate, low blood pressure, and sometimes arrhythmias. Okay, but generally patients have to be pretty low rate and pretty sick to start having those symptoms. Lanugo, that's the fuzzy fur hair, loss of menstruation. For bulimia, there's additionally the bilateral parotid gland enlargement, the scars on their hands, the tooth enamel erosion. Interestingly, that even when they are normal weight, bulimia is associated with more severe QT prolongation than anorexia. So always insist on an EKG. How often should you get an EKG? You know what? I tried to find guidelines on that and I couldn't find anything really specific. So I think it's just like if your patient status changes. If the EKG is abnormal, I'm going to get it pretty frequently and maybe send them to the hospital. Cardiac complications are responsible for 1/3 of the deaths related to eating disorders. That's because weight loss decreases cardiac mass. And so you get loss of your ventricular output, lower cardiac output. That's why they get low heart rate, low blood pressure, decreased metabolic rate. And then the QT prolongation can lead to cardiac arrest. Ipecac abuse in particular can cause irreversible cardiomyopathy, so watch out. And then, of course, the endocrinological issues, very high rates of polycystic ovarian syndrome in eating disorder patients. So I've heard that a lot of OBGYNs are diagnosing people for the first time. And then, of course, hypothalamic hypogonadotropic hypogonadism, low on the sex hormones. Thyroid abnormalities are very common. Anemia and thrombocytopenia leading to bleeding and increased risk of infection. Then there's delayed gastric emptying. So they can get gastroparesis. Interestingly, high cholesterol, and then superior mesenteric artery syndrome. And that usually presents as severe pain after eating. Bone mass is affected. So it's particularly scary if women are developing anorexia during puberty. Prior to hitting adulthood. Lower bone mass can cause permanent osteopenia. Because there's the critical window in adolescence in which women are accruing most of their bone mass. I learned in my reading that apparently the trabecular bone of the lumbar spine is particularly affected by anorexia. So for medical monitoring, then that includes the DEXA scan, the EKG, the thyroid, complete metabolic panel, including phosphorus and magnesium, CBC, calcium, magnesium, amylase, lipase, prolactin, estradiol, testosterone, vitamin D, thiamine, ferritin, B12, zinc. Consider FSH and LH testing. These are things that I'm kind of breezing through because then you could just use these slides as a reference later. The most common electrolyte disturbances are low potassium and low phosphate. If someone's vomiting a lot, you're going to worry about low hypochloremic metabolic alkalosis. And for laxative abuse, it's going to be high hyperchloremic metabolic acidosis. Now, when weight is being restored, watch out because calorie needs dramatically increase as soon as the patient starts to gain a little bit of weight. So they have to take in a lot more calories than you think they need. The brain and body are so used to starving that the metabolic rate has been so low, and then it gets food and it ramps up fast. This can also cause the refeeding syndrome. The body starts metabolizing glucose, and levels of phosphorus, magnesium, and potassium can drop fast. And that can lead to cardiac failure from cardiac arrhythmias. So if someone is very low weight and they need to be refed, consider hospitalization, consider phosphorus supplement, which you can get over the counter. And then when do we need to send these people to the hospital? It's actually, the criteria are clear cut. What is less clear cut is how well you can hospitalize them involuntarily. There's a lot of debate, and I think that the choice should be made on a case-by-case basis. The heart rate less than 50, blood pressure low, glucose low, electrolyte imbalances, low temperature, or any signs of organ compromise, they should be in the hospital. And in my practice, I would involuntarily hospitalize them if they refuse. Fortunately, for me, as a child psychiatrist, though I do treat adults too, but fortunately so far, all of the cases that I've had to hospitalize for these criteria have been children and adolescents. So it's pretty clear cut that the parent can force them into the hospital as their legal guardian. It becomes more difficult and more challenging when it's an adult. And then how long are they going to stay in the hospital before they sign themselves out? So this is an area that it's difficult because these patients, you know, present very rationally a lot of times. They're not like a psychotic patient, right? Who's going to be yelling and, you know, thrashing. And so the police are like, okay, of course, right? We're taking them away to the hospital. These patients will speak very logically, but they are still just as delusional and stuck in their eating disorder. So I think this is something we can continue discussing as a society, you know. There's also a lot of recidivism, that once they get out of the hospital, they start starving themselves again. So it's like, you know, how long do you continue that cycle of forcing them into the hospital? Consider a residential program if they don't respond to outpatient treatment. If the weight continues to be less than 85%. A lot of patients really need the structure of residential treatment or at least day treatment. Especially for patients who don't have a lot of family support. So, and I'm going to talk about how important family involvement is. So like anorexia and bulimia treatment includes this whole team: psychiatrist, therapist, primary care, nutritionist, and the family. I really have yet to meet a really ill eating disorder patient who came to treatment, stayed in treatment, did the treatment plan for their own health or their own life. It's always for their child, for their parent, for their boyfriend or girlfriend. It's always for someone else. You get more traction, a lot more traction in getting these people's buy-in into treatment when you include family, and a lot better results. So family inclusion is key. And you're probably asking at this point, okay, well, how do we get them to do this? How do I get my patient to go to the psychiatrist, a nutritionist, to this, to that, right? And it can often take time. So I think of the analogy as like, you hold the door open, you can't drag them through it. You can hospitalize them if they're that ill, right? But most of the patients that you're going to see who have eating disorders are not going to upfront meet criteria for hospitalization, right? You cannot drag them to treatment. So you're holding the door open. You're like, look at these awesome things on the other side of this door. There's freedom, less anxiety, health, not having to have bad breath all the time, all these awesome things. Like imagine, like I have them visualize what your life would be like if you woke up tomorrow and you didn't have an eating disorder. What would that look like? You know, how awesome would that be, right? So you're giving them reasons and you're eliciting their reasons. And then you're also giving them hope, like confidence that they can get there. Like that's kind of an analogy, like, okay, look, here is this clear path through this door that I'm holding open for you, and we'll hold open as long as it takes, step by step. So our job here is to hold this space and not give up until they're ready to walk through it, and keep holding the line. It's not easy though. And I mean, honestly, my biggest gun here is getting a parent or spouse in the door, and explaining to the spouse. Actually, I remember having an intake with an eating disorder patient, where like 15 minutes into the appointment, she screamed at me and she ran. And the husband was in the waiting room. And he was like, damn. And I was like, nah, don't worry about it, man, because you're going to finish the appointment with me. I spent the rest of a 90-minute appointment, like 15 minutes with her and the rest of the time with the husband, strategizing what steps he was going to take to keep her coming back to my office. She's actually doing much better now. But like the bulk of my intake was with the husband, not my patient who ran away screaming and left me. And we were able to laugh about it later, but like a year into treatment. So explain to the spouse, this is a brain disorder. It is not something their loved one can snap out of. or something they chose, and it is life-threatening. So in psychiatry, we have this concept of externalizing the disorder. It's the eating disorder, not the loved one themselves. Okay, so you got like, you know, Jack, the husband, and Sally, the wife, and so instead of Jack versus Sally, you need to eat. No, you're trying to make me fat. It's Jack and Sally together against the eating disorder. In the book written by the country singer with the eating disorder, Jenny, she names her eating disorder Ed, and that's why the book is called Life Without Ed. And then separates the eating disorder thoughts from her thoughts. Teach spouses to have an empathic, non-judgmental stance. They always ask, why did this happen? I don't understand. Did I say something? And you're like, nope. We may never know why this happened. No one is to blame for the illness. Let's focus on what needs to be done to help your loved one recover. Coach them about focusing on health and psychological recovery, not physical appearance. Don't say, oh my gosh, you gained 5 pounds and you look so much better. Say, oh, the therapist says you're making great progress. I'm glad you're feeding yourself and you're getting healthier. Keep shifting the focus to health and freedom. Also empower spouses to have an active role in preparing meals, encouraging, not forcing their loved one to eat, attending the nutritionist appointment and other appointments with their loved one, setting up barriers to eating disorder behaviors so they support and empathize with their loved one, but they say, I do not tolerate the eating disorder behaviors. I love you. I'm not okay with you purging. I love you. We're getting rid of the scale. You, I accept as you are, right? But I'm going to help distract you after you eat so you're not in the bathroom. I found a cool article online on do's and don'ts for spouses. With your patient, you do everything you can, decrease shame. This is an illness and not a personal failure or character flaw. And we recognize that it's their best way to cope with extremely painful feelings. Teach them to distinguish the eating disorder from themselves, like we've talked about with that externalization. Cognitive therapy is helpful to reframe and contradict eating disorder thoughts. Help them to cultivate sources of self-worth that are not physical and get away from comparing themselves to others. This is an expression I stole from a book I read, Compare and Despair. It's very true for eating disorders. As I talked about with the hold the door open for them analogy, okay, we want to increase their desire to change, elicit the reasons they have for changing, and we want to increase their confidence in their ability to change. Hope, okay? Those are the two components that get people moving in the right direction. Oops. When your healthy self, sorry, I'm trying to read this, but my screen is getting blocked. How do I make this small? Oh, there we go. I can move it. When your healthy self is strong enough to deal with all that comes your way in life, your eating disorder self will no longer be useful or necessary. So it's about strengthening that healthy self. This is a great book, and it comes with a workbook too for the patient, 8 Keys to Recovery from an Eating Disorder. So it's written by a therapist who has an eating disorder, who's communicating with their therapist, who's recovered from their eating disorder. So very interesting. It helps you get perspective. Now we're going to go over medication strategies. So the bulk of treatment for an eating disorder is the therapy, and that is why I spent so long on that. I'm just kind of understanding these patients psychologically. So SSRIs have the largest body of evidence, okay? Also evidence for some tricyclic antidepressants like clomipramine. But like we touched on earlier, In studies where weight is very low, and is not going up, SSRIs don't separate from placebo in terms of their effectiveness in decreasing the obsession with low weight, decreasing the eating disorder thoughts and behaviors. There's a lot of comorbid OCD with eating disorders. Zinc supplementation, in 3 different randomized control trials actually found zinc superior to placebo for restoring weight. So that could be like a great little sneaky tool in your pocket, because patients with eating disorders don't want to take anything that they think is going to cause them to gain weight, and not many people associate zinc with weight gain. Okay, and olanzapine. Yes, olanzapine is awesome for gaining weight, but it's very hard to get your eating disorder patients to take it. Okay, it also helps with some of the OCD components of eating disorders. There's this study on medical marijuana and it was negative. So there really is no place for medical marijuana for eating disorders. All right, bulimia is next. Okay, sorry you can't see that well, but this is the bulimia slide. Okay, so SSRIs still are winning out in terms of the largest body of evidence, right? But it's higher doses. So the therapeutic doses in the trials was at least 60 milligrams. And there's also some evidence for sertraline and fluvoxamine. Topamax reduces the frequency of binging and purging in 2 double-blind randomized controlled trials. It does have some memory issues, and it can cause word finding difficulty. I've actually had some good luck with naltrexone because a lot of my patients don't like the memory side effects of Topamax. So I know naltrexone has mixed results. It's fairly benign in terms of its side effects. And I've had it really help patients, and they kind of like, I could say, hey, if you're going to go out to your kids' like birthday party or have pizza, and you know that you're going to in particularly be tempted to binge and purge, take some naltrexone, kind of like people do for alcohol use. I've had some good results because patients like having a medicine they have some control over that doesn't have weight gain as a side effect. Okay, avoid Wellbutrin because of increased seizure risk. So if you're going to prescribe a patient Wellbutrin, please screen them for eating disorder. All right, let's go on to binge eating disorder. Before I go on to binge eating, we're getting towards the end now. I'm going to pause and take some questions on anorexia and bulimia. Questions, guys? Andrew's saying a lot of the CBT sounds like the techniques for OCD, which is true. I think there's a lot of overlap. Yeah, questions?
Yeah. Dr. Creator, thank you so much. It's really, really helpful, all the information
Thanks, Dr.
you're
Lou.
describing. And just to kind of echo my experience as well, it's very, it can be open for, I do outpatient, and so it's very much I view it as kind of a marathon, right? So, definitely, I don't feel like I'm going to take care of every single thing in one appointment. But I do think that, the rapport building, making sure people are comfortable talking about it, help anchor me at least as far as like what I can do in the moment. And I really appreciate you describing some of those things that you say to your patients. That's really, really helpful as far as kind of what to do. And I just want to stress too, even if ideally there's an eating disorder programs in your area, but if they're not, like in Tulsa, we really, I have to kind of create it on my own, right? Coordinating with a pediatrician, coordinating with a nutritionist, coordinating with different providers, the therapist, to help these patients. But it's definitely doable. And then, like you said, the parents, at least for the patients that I take care of, are huge resources that really involving them, empowering them, I feel like really helps the patients. And so, yeah, thank you. All of that really resonates with kind of my experience. I practice in Oklahoma, which is a far away from Florida, but all of it kind of makes sense, and that's what I see as well. So thank you.
Thanks, Dr. Liu. Do you have any great pearls that you say, great that I can steal too? Not to put you on the spot.
I can't think of any
or favorite metaphors or analogies.
I know. Fortunately, like you said, or unfortunately, I guess, depending on how you want to view it, the eating disorders, I can think of a handful of patients who have told me about it, and very much like you described, not everyone discloses it. But I found that, typically, and again, whatever's within your control, but I find that these are typically longer appointments, just because, teasing out the depression from the anxiety and the eating disorder, they're oftentimes really commingled, if that makes sense. And so trying to parse some of those things out can take time. And so I find a lot of my med management visits, because a patient I'm thinking of has an individual therapist, but sometimes the medication management visits do extend a little longer. And fortunately, I'm at a place where it's flexible to allow for that. And so I find it definitely takes some of the pressure off if you have more time to explore some of the symptoms of eating disorder, because inevitably, like you described, comorbidity is very common. But yeah,
you see a lot of comorbidity between bulimia and ADHD. I see that a lot.
Yes, that's very common, and I think I really appreciate you describing the like psychological types and kind of examples, because that's consistent with what I see. And I find a lot of times too, obviously I'm making diagnoses based on the DSM-5. However, right, on a day-to-day basis, as far as like a litmus test of, anything that are like, raising red flags, I do look for those kind of personality types and descriptions. And exactly like you described, the patient that I'm thinking of, that when you talk about eating disorders, specifically for anorexia, is a high achieving, rule following, cheerleader, very, very, high standards, and definitely not the prototype like you were describing of someone who's impulsive and, doing dangerous. That is not her at all. So, I think your examples pay out, at least with the patients that I see.
Yeah, cool. Thanks, Dr. Liu. All right. Any other questions or comments before we go to binge eating disorder?
I'm just wondering.
Yes.
Are all the SSRI, is fluoxetine like far and away better for anorexia, or? So
we don't have comparative data. You know what I mean? Yeah. Which sucks, because that's a problem a lot in psychiatry. I'm sure Dr. Liu will agree that maybe Zoloft could be better. Who knows? It's like we have a large trial that used fluoxetine, so we're going to use fluoxetine. You know what I mean? We just have more data for it, but we can't say that it's actually better. So, if you're starting with like a medication naive patient, sure, I'll go with fluoxetine. But I don't know, let's say the patient is like, man, I heard about Zoloft and I would love some Zoloft, and my mom takes Zoloft and I have good feelings about Zoloft. Okay, sure, great. They have positive feels about Zoloft, right? I don't know. What are your thoughts, Dr. Liu? Would you agree on that?
I agree with that as well. And again, too, like Dr. Greeter is saying, I primarily work with children and adolescents, and there's definitely reasons to pick one SSRI over another, but I have yet to find a study that breaks one SSRI like clinically, in a randomized controlled trial that's better than another. I know you guys see it all the time, I'm certain, where certain patients say, oh my gosh, Lexapro, that's way better, it's worked wonders for me, but fluoxetine, never, Prozac, never prescribe that to anyone. I've never seen a study that parses that out. And for what it's worth, I think that's a very reasonable question. And I think it's things that, people look into, but I have yet to see a head-to-head comparison with SSRIs that bears out one is clearly better for treating a certain disorder than another.
Like even the STAR-D trial that we do have, it's like, you know, so for a group of people, you get a big group of people together and you give them a few different meds, there isn't going to be an SSRI that comes out above the others. However, for a particular individual, do not be surprised at all when they're like, gosh, I hated Prozac and I love Lexapro, or I love Lexapro and I hated Prozac. And so it's like the best medicine for you is just whatever works for you. Yeah, on an individual basis. Good question. All right, binge eating, and then I'll take more questions at the end, okay? Okay, all right, hold on. All right, share. Okay, binge eating disorder. So, basically, what is the criteria for a eating binge, right? Because lots of people are like, oh, I had an eating binge. Okay, so this is eating significantly more than what a typical person would eat. Well, that's really clear. Okay, so the DSM-5 isn't extremely specific on this, but it does include a lot of psychological symptoms while eating this extreme amount: feeling out of control, eating rapidly, feeling uncomfortably full. Actually, patients can have gastric ruptures due to binge eating disorder. You know, not feeling hungry but continuing to eat. And some of my patients just feel this compulsion to eat. Even it's like dusting food out of the trash. Or it's like I always have to eat my kids' leftovers just because they're there. It's like they're calling to me from the fridge. I don't even like what my kids had for dinner, and I gotta eat their leftovers. Being embarrassed about how much one is eating and feeling disgusted, depressed, or guilty after the overeating. Okay, so I stole this picture from Psychopharmacology Institute, which is a great resource, by the way, for keeping up to date, because I thought it was really funny that for binge eating, the patients on CBT and placebo did better than the patients on CBT and fluoxetine. So anyway, so SRIs, while they have data, good data for bulimia and anorexia and somewhat for ARFID, don't pan out for binge eating. It's kind of a different beast. Stimulants have the best data. And yes, Vyvanse has the FDA approval, but there are positive trials for methylphenidate too. Vyvanse just, you know, people are making money off of it still because it is a brand name medication. So it went to the effort, the pharmaceutical company, of course, went to the effort to get that FDA approval. But I would imagine that pretty much any stimulant is going to be helpful. Dosages of 50 to 70 milligrams were most effective in the trials. Low dosages like 30 milligrams did not separate from placebo. And the therapeutic effect does not appear to be via appetite suppression. The therapeutic effect is via impulse control, increased impulse control. Stimulants are first line for this. And there's a lot of debate. Is binge eating an impulse control disorder? Is it an addictive disorder? We lean towards impulse control disorder, especially because atomoxetine has also good evidence behind it for decreasing the obsessive food cravings, decreasing the binge eating. Duloxetine has a positive trial. I thought that was pretty interesting, especially since fluoxetine didn't separate from placebo. Topamax reduces binge eating. Zonisamide, camprosate and naltrexone kind of mixed, you know, not showing clear efficacy. Somewhat indicating that binge eating is more of an impulse control issue than a food addiction. So the slides I'm going to put in my resource sheet, so you don't have to worry about copying this stuff, okay? Where you could directly go to these links to download these eating disorder screening questionnaires. I like the publications by the National Institute for Mental Health, pamphlets that you can print for patients. The National Eating Disorder Association again, NIMH. Recoverywarriors.com is a great resource for patients with eating disorders to connect with other people in recovery. And the Rise Up and Recover app is a tool that helps patients monitor their feelings before they eat, the feelings after they eat, how often they're binging, keeping up with their nutritionist guidelines. So I think that's a great resource too. My favorite books so far are The 8 Keys to Recovery from an Eating Disorder. Like I said, I think it's really accessible. That's the one that's written by a therapist with an eating disorder, talking to her therapist who's recovered from her eating disorder. And then Life Without Ed, which is written by the country music singer. And I'll let you listen to her song for a little bit too, because I mean, how often do you get people writing songs about a topic that you're doing a PowerPoint presentation on in psychiatry? I'm going to get it going. And then I'll take final questions and wrap up for the night, guys. I'll definitely repeat this for my Florida people who all lost their electricity tonight. Oh, it's already here. Hey. Share. Okay. I hope this works. It says share sound. Let me do this one too.
I was chasing down the image for so long of that perfect girl that I just had to be. She was never quite the one I thought I saw. How I let that dreadful mirror torture me. It was killing me to try to look like her, the amazing woman who could turn each head. I was losing so much more than all the weight. My very heart and soul were left unfed. I called the monster Ed. He so controlled my head until a greater power spoke the truth. It said life without Ed is waiting here for you. Be strong, keep the faith, and you'll see it coming true. You don't have to just pretend. All the pain can really end. You deserve more than the lies that you've been fed. You can believe in life without Ed.
All right. On that note, hopefully that gets you guys interested in checking out her book. Comes as an audiobook. I listened to it while working out. And some of the other great books. I think that giving information and referring to books is a great way of helping getting patients' feet in the door and giving them a little hope, reading about other people who have recovered from eating disorders, that they too can recover, and that can get them in a psychiatrist's office or into a therapist or nutritionist office. So now I'll take final questions. Any final questions before we wrap up? Hey, Dr. Lee, Julie, thanks for joining us.
Yeah, this is awesome.
Again, anyone who is not on the email list, who hasn't gotten emails from me and wants to, put your email in the chat box. Thanks. Hey, Julie.
Hi, I had a question. What did you find with the atomoxetine for binge eating? Have you noticed it been being helpful?
I haven't used it yet. I haven't, because I almost always use stimulants and some naltrexone because people don't like Topamax. What, have you used it?
Well, I mean, I use atomoxetine for my ADHD folks, but I haven't heard anyone say anything about the eating part really changing that much.
I honestly didn't even know till I did the research for this presentation that it had good data behind it. So that's cool, because, you know, not everybody tolerates stimulants. And so it's good to know that that's an option for us as well. Yeah, good question. Other questions, guys?